anything that is necessary for the patient to save the patient or to help the patient to survive, we give the IV. Not we, I mean the nurses, the hospitals, they give the IV. Now, why you are there? What's your role? What is your role?
Drawing blood.
To collect
Drawing blood, that's
collect
it.
blood.
Collect
Yeah.
blood, that's it. Sometimes the nurses are trained, they do that. If the patient is really critical, for example, for the patient who have experienced heart attacks, only after 2 3 days you will be getting a chance to go close to the patient to draw the blood. In majority of the cases, that's what I have seen. So there'll be nurses, trained nurses. They will be close to the patient. Why it's very critical when it comes to the IV situation. So if they want to test something really, really critical, like I have seen, the nurses, special trained nurses are there to take the blood. So when you are there, probably you'll be taking blood for the less critical patients, even in hospitals. So that's what it means by nursing staff or other specially trained personnel, but the nursing staff also do the job when it is really mandated for them. Types of VADs, we're going to see what are the types. This is just for a knowledge sake, as I told you in the beginning. You don't have anything to do, even it's a catheter or IVs or arterial line. Just I'll explain what they are, just to have a knowledge. IVs, we all know intravenous lines. IV catheter locks, usually in the form of the catheter is usually given for the in the bladder for the old patients or the patient who have kidney issues where the urine is not drained. They put the insertion in the bladder. It's called the urinary catheter, just to drain the excess fluid that's been there in the bladder and to save the patient. And there will be saline and heparin catheter, which means when there is a catheter inside, to clean the catheter to keep the patients free of infection, they will do the saline catheter. Where, continuously, there'll be recycling of this fluids to eliminate the infection, to avoid the infection. Arterial line. Arterial line is sometimes we have to check for the blood gases. It's something which is called a STAT, emergency situation. When ammonia is the main reason, like there's the protein metabolism is not good. Ammonia is a byproduct that will be accumulated and will be there in the blood. It's poisonous for the patient. The patient may die. If they find something is wrong like that, that's called the STAT condition. They will put the A line. A line is something what we call the arterial line or ART line. This is what they refer. And arteriovenous shunts, fistulas or grafts, this is they cut the small area and then they insert the tube if they want to get the blood in a combination of arterio and venous blood. This is what we call inter. The way they connect will be inter. One artery, usually they do this in the radial here artery here because they want to check something. This happens. There are diagrams you'll be seeing that. That's called the shunts. It'll be inside. And you cannot touch that unless you're not specialized to collect the blood. So here the nurses are trained, they will do the job. It's not for your scope of practice, but you should know. Central vascular access devices, these are all it'll be there in the venous where the blood is pumping out. Mainly when the blood is collected, usually it's in the right-hand side. It's a major area where we have the vena cavas. They put it there because they want to know what is happening in the circulatory system. And then they have, these are for the critical patients. We call the central venous line CVC. And implanted port, this is once again, if something is inserted inside the body and then they want to test repeatedly, they insert the special devices. Another is PICC, peripherally inserted central catheter. This is another thing. There's a diagram. We will see how it's been inserted. What you have to know now, you're not doing anything. Just the definitions. What is IV? What is an IV? Types of IV catheter. What is an arterial line? What do you understand by arteriovenous shunts? Examples, fistulas or grafts. What are the central vascular access devices or indwelling lines, which means it will be there. It will be there inserted inside, because whenever they have a condition, when they want to go to the hospital, they don't have to perform a small procedure to insert that. It is already inside. That's why we call indwelling lines. It's dwelling inside your body. Now it's there with your system. Types of them, CVC, implanted port, PICC. These definitions you have to know. Any questions? Because this is from the exam point of view, these definitions are important. Any questions? Questions?
No, ma'am. Thank you.
No. Okay. Just for the definitions this whole topic is for the exam point of view. That's it. Except three things. When the IV is there, how to draw the blood, where to draw the blood. Okay, and how to perform the procedure when there is a complicated situations. This is why we are learning this. Other than that, you're not going to perform, so you're not going to break your head. Just for the exam point of view, some of the things, definitions you should know. What are the IVs? Catheter, this is the device inserted into a peripheral vein, which is peripheral means surrounding. So other than the central body, the abdomen or chest, if something is inserted in mainly the hands, sometimes in the legs, they do that, but mainly they do it in the hands. So we call them intravenous lines. And catheter connected to tubing used to, now this is something that there is a tubing that's inserted. For example, if a patient is coming to the hospital, if it's going to be there for 3-4 days, they will insert a hub, the device, which is the catheter. And with the hub, you have to every time, you have to close that. And then from underneath, you have to draw the blood. When sometimes they don't get the blood, they will insert in the hub itself to get the blood, because they have to draw the blood. The other alternate way of collecting the blood, as per the physician, if you say we are not getting the blood in the IV patient and both the hands have two different IVs, it's so a critical condition that the patient came in the hospital, 2 IVs have been inserted in both the hands, still you can get the blood. The alternate suggestion for the type of test, he may suggest what?
Capillary.
Capillary. Capillary. Now, the doctor is telling, I don't know, I can't get the something from the capillary. Can you try to get the blood in the vein? That's the last option. The last option is there is a hub attached to the device. You will be drawing blood from the IV line itself. Clear? In this,
Yes.
there may be so much fluid that's associated with the blood. So they have to first pump out the fluid. It's like a tedious process. Every time you pump out so much fluid to get the blood. But they want to see something in the veins. So there is another possibility. Okay, that's why catheter connected to tubing used to administer fluid is also used. May have a drip chamber to control flow rate and prevent air bubbles. Of course, all the catheters or the devices, they have something like a control mechanism to prevent the air bubbles. And specimens drawn from the IV arm can be diluted with IV fluid. So the results won't be good, we know. So what we have to do, we all know, even before, when there is an IV, we cannot draw the blood directly from the IV. Then where will we draw the blood? Any idea? Top of the IV, bottom of the IV, where?
Below the IV line.
Below the IV. Very good. Why?
Because of the flow of the IV, the solution
Because
is
it will be,
going all
yes,
up. Yeah.
it's moving towards the heart, so there'll be a mixing of the fluid with the blood, so it will affect the results. So tie the tourniquet below the IV line and then look for the vein below and then draw the blood. The first possibility, the first thing. What if the IV is somewhere where you cannot draw the blood? The doctor may suggest.
It will be the opposite hand, ma'am. If it's
Very good.
not possible,
The first option is the other hand.
opposite, yeah.
If there is a fistula already in one hand, now the IV here in the other hand. Now, as a technician, you're going looking at the patient. What will you do?
If that is the case, then we ask the nurse to stop the IV and wait for 2 minutes before collecting the blood.
Yeah, that's it.
Yeah.
Now, she made a simple sentence, but you know, you may get 3-4 questions in this. First thing is, can you draw the blood above the IV line?
No.
Yeah. Second question. What if there is an IV line? For how many minutes you have to turn the IV line off?
2.
2 minutes.
2 minutes.
2 minutes is
10 minutes.
officially 2 minutes is officially documented in books. But I told you when I attended the CSMLS questions, I was
10
looking
minutes.
for 2 minutes. 2 minutes wasn't there. For me, the options are 10 minutes, 20 minutes, 30 minutes, 1 hour, or 1.5 hours. I was looking at the question sitting there. I was thinking, where is the 2? The 2 is missing. What is the close number?
10.
The 10.
10. I just assumed, okay, if 2 is not there, that's not my problem. Let me circle 10. Even though the books say just a minimum 2 minutes, some of the books, they mention minimum 2 minutes, at least 2 minutes, which means 2 minutes is a standard. It can go above. Depending on the patient's situation, if the patient is badly dehydrating, if you keep the IV line locked for a half an hour, 1 hour, it's not good for him. That's why the at least 2 minutes is recommended. But depending on the situation, it can be 10 minutes, 15 minutes, the max. Be specific with the answer, know the range, and choose what the question is like asking, and then answer. Clear? Now we have this information, you're telling, okay, miss, this much, everything, but if you're not able to pick the right answer, then what's the point of learning? So keep this in mind. Now we are going to see. So they are attached a syringe to draw the blood from the IV line. This is a possibility. Can you see the syringe?
Yes, miss.
Yes.
Which means the doctor demands a venous blood.
Yeah.
And here in this condition, before that, they have to discard so much fluid because it will be diluted with the blood. So that's what they have to pump more fluid and throw. And then that's why they prefer not to touch this. And then they go to the maximum, the other hand or capillary puncture if they want to see something. It all depends on the doctors, what they want. Actually, not on the doctor, depends on the patient's condition, the body condition. Now, what are the strategies? Look, everything that is read in the slides or from the exam point of view, they are very, very important. Just note it down. Revise this repeatedly. Keep the information ready in your mind. You will get questions. IV in one arm. Collect the other arm if possible. IV in both arms, collect below the IV site using the following procedure. Now we are landing into something really, really important, right? Not only from the knowledge point of view, from the exam point of view. As nursing staff, so who is touching that again? Who is
The
touching the
nurse.
IV?
The
The
nurse.
nurse. You will be getting a question. The IV line is there, blah, 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 blah. Then can you turn off the IV? True or false? You can turn off the IV. True or
No.
false?
False. False.
False.
So these things, you should know how to answer. This is important. So ask the nursing staff to turn off the IV for at least 2 minutes prior to collection. But is this always 2 minutes?
No. No.
No. Look at the wordings. At least 2 minutes. I explained this in detail. I'm not going to repeat this. Keep this in mind. This is outside the MLAT scope of practice. Time allows fluids to dissipate from the area, of course, but the time can be altered to 10 minutes to 15 minutes based on the number of tubes that you're going to draw. Okay? We want perfect results. We don't want the false results. Apply tourniquet below the IV to avoid disturbing the IV. And then select a venipuncture site distal. Distal means below the IV. Okay, proximal is close to the IV, little bit away from the IV. And then tie the tourniquet. Venous blood flows up to the arm towards the heart. So collecting below the, okay, this we know what we are doing. So we have to collect the blood. And this will be free of contamination if it is below the IV line. No contamination, results will be good. The blood flow will also be good without any mixing up of IV fluid. Now, what are the strategies? Again and again, it's repeated. If there's an IV, okay, look for the other hand. If it is, you go below the IV site. So take some time before collecting the thing. Make sure that the fluid is not circulating there. That's why I told you 2 minutes is the least one. So usually 10 minutes is okay. Ask nurse to restore. Who is touching again? The IV, not you, the nurse. If someone comes and tells you, if the doctor is entering inside the room, you know what? The doctors, they don't have an idea whose job is what. Seriously. They will just enter inside the room. When you're there, they will tell you, can you do this? You have to say, no, sir, I cannot do. I'm serious about this because I have experience when I was in the clinic. Can you give this injection, B12 injection to the patient waiting in that room? I said, sorry, sir, this is not under the scope of my practice. I told the doctor. Why? Because they don't know. They don't know whose job is what. Their job is to come visit the patient, ask him about the condition or look for the condition when it's documented. The nurse documents. We document for the blood draw, and then he will look for what test has to be done, what has been completed, what has not been completed. And then now, if these things are not completed, the doctor is ordering something for to see something in the body. And whose job is to draw the blood to see is our job. We have done that. We're sending it to the lab for testing. If something comes out of the lab, then only the doctor can do something or prescribe the medication. So look how important we are. If he doesn't receive the results, he has to sit in the office doing nothing because he has to see the results. That's why the lab has become a very valuable resource for the medical field. Right? So we are important. Now, document the specimen was collected from the IV arm. Again, documentation is important. What type of fluid was that? Now, they also want to know what type of fluid has been inserted in the patient's body. Why? Why? Of course, we are closing that. We are collecting the blood below. There shouldn't be any mixing up of fluid. Okay, we understand, but still we have to document what type of fluid was there in the IV line.
Yes, in case it interferes with testing or changes
Very
some.
good. Very good. If
Yeah,
you're collecting
especially
to
electrolytes.
very good electrolytes, even the glucose, some people they may be diabetic at that time when they come there, they don't have energy or something, they may not be having sufficient the sugar level, so they may be usually inserting, they do the what kind of thing, the sucrose is the one that they insert, the different categories in that, and accidentally there's some mixing up of the liquid with the blood, and when they maybe a minute drop or something, if they send the blood to the lab, they find that the patient is again diabetic, which is not really at that time. So the doctor will see, just the doctor doesn't know, he will just see the results and they'll say, okay, this patient is still diabetic, let me increase the dose for 3 more months. Till the 3 months, the patient has been a victim of what? Drug abuse.
Yes, hypoglycemic.
Really? This, what will happen? This affects the organs, kidneys.
Yeah.
And the healthy patient, because of our negligence, may end up in some other situation where he has to walk to the hospital every time. And who are responsible? We are responsible. So we want to avoid all those situations. That's why it's very critical. Document, document, document. That's why they say document. Okay. So they will double check if they see, okay, already this person was inserted this in a bag and the fluid is there in the system. So when they draw the blood, when they document, they will check, is really it's high, or is there something mixing up of, could be mixing. Okay, let us check, take the blood after 2 hours and see how it's going. So they will check again. When the results are not like up and down, then they will wait to take, this is how they perform, because they want to make sure that the patient is healthy. And the healthy patient shouldn't be ending up and coming to the hospital again and again because of the careless situations, mainly by the technicians. That's why we document. That's why, and by seeing the results only, the doctors will analyze what's happening, what's going through. That's why testing is very important. If neither arm is available, depending on the test order, I told you, it's all repetition, the capillary stick or the finger stick. Some may have to be collected from the IV itself. See, when the blood is collected from the IV itself, is it the scope of practice for us? Does it come under the scope of practice if the blood has to be collected from the IV directly or directly?
It can be.
Can be, depending on the situation, but still it's an IV. So that's not for us. There'll be specially trained nurses to do the job, because the more fluid will come, they have to flush out the fluid to collect the proper blood.
Yes.
Right? So it is
Yeah.
outside the MLAT, again, it's telling in red, red, which means questions. It is outside the MLAT scope of practice to collect from an IV or any other vascular access device, period. Some of them, the hospitals, they give special training. That's possibility. You might be a phlebotomist, but to touch the IV and do that, there needs to be a special certification. If the nurses are busy in some situations, when you have to be there, it means you have to have a proper certificate. You are trained in IV. They'll give you the training in Sick Kids Hospital and the UHN, University Health Network, network hospitals like St. Michael's, or what do you call the, there's so many, St. Margaret, all those things, all those hospitals, they train. They give a training for 6 months to 1 year period when you're hired. Note, collecting through the IV can cause, why they are very, very critical about this, it needs special skills, special training. So majority of the specimens, when they are collected through the IV, they are hemolyzed, already disturbed, the RBCs are disturbed. They're ruptured partially. Now, if a patient had an IV when he was in the hospital, he went home and then something happened, he is coming back, and there was IV already in one hand, don't pick the same hand, look for the other one. Okay, if you want to insert an IV, even in the inpatient, when there is a condition, you have to draw the blood again. Okay, and insert the IV again. Don't look for the same hand, look for the other hand because it's painful. There may be contact. Sorry, guys, some bacteria has entered. I think so. So it's 24 to 48 hours. For 1 or 2 days, you don't touch it. Maybe after a week, if they come, it's a possibility because there'll be a source of contamination. It may hurt, they may get infected, so be careful. So whatever these hospitals are telling you, because these conditions are in the hospital, so follow their instructions, what they say, how they perform. This is another way of devices. They're not going to ask you this in detail, how it will look like and everything. This is for your own idea, for knowledge purpose. Needles, a collection device in the form of it's not needless, it's needles. Collection device in the form of a stopcock or cap. Can you see the picture here for the first one? A cannula will be there. And the tubing is very short. Cannula is something you will attach and then you draw the blood. And the other way has a thin rubber like this, like a cover that provide access for giving medications or drawing the blood. So both are there. One is you can draw the blood. Can you see the green one, the median cubital? That's for drawing the blood. The other one, the tubing going up, is like for the, no, this is for 2-in-1 for sure. You can draw the venous blood and then as well as you can give the medication. It's an access. It's a device that you can access for both. These are examples. Can you see this? Don't worry about these things. When you go there, you will have an idea. Don't even worry about these things. Look for the red ones, the red lines in the slides. That's for your questions. And catheter lock. This is something a device is placed in the vein at the back of the wrist here, left in place for up to 48 hours. And so to avoid the clotting procedure and for the any contamination, they usually flush with the saline or heparin. We all know heparin is an anticoagulant. So in order to avoid the blood clotting, they flush it with the heparin or saline. And the most common one is saline because it's easy, cheap, and it's good. That's why they use the saline ones for flushing. If nursing staff is collecting blood from a heparin lock or a saline lock, the first 5 ml should be collected into a discard tube. Why? To avoid the contamination of heparin. So this is a procedure that's done by a nurse to avoid the clotting of blood. And once again, when they do this, they have to collect 5 ml in a discard tube. They have to collect the 5 ml, what do you call that? You know the colorless tube that we have? We call that the discard tube. I'll show it when I come back. It's not, it has a red color, but inside the cap, just at the top. That's the discard tube. The hospitals, they have that. This is where they discard the blood. If they have some contamination, if they insert some medication, if they want to collect the blood, sometimes this is the one I have seen this. It's there in the lab, just to demonstrate. So they will take the blood in that tube and then they will discard. If the heparin treatment is given, just to keep away from the blood clots, because the blood clots will interfere with the test results. So, but this is not to test for the coagulation blood, which is the blue, for light blue tube, this is not the good thing. That's why they say they don't do this for coagulation purposes. And arterial line, what is arterial line? What did they say about this? It's inserted in the arteries. Now, I want to know something about the arteries. What do you know about the arteries?
Oxygenated blood.
Very
They are
good.
not. We
And what
don't
is the color?
collect from an arterial line.
Bright red.
Usually we don't collect it, but there is a situation when they have to collect it. Then what is the color? Kara, yes, very good.
Red.
The blood gases.
Right. Yeah. Mainly for the blood gases, I told you, the protein metabolism, the end product is the what do you call the amino acids. If something is not wrong, then it becomes ammonia. It'll be there in the blood. It's very it's not good for the patient. So it's something that's really critical. When a patient comes with those type of symptoms, immediately they have to collect the blood. It goes to stat. Generally, the stat is collected in which tube?
Green.
Green, light green. The lithium heparin, light green, that's for the stat. So when the patient, no, this has to be collected and kept it on ice. The tube will be on ice. When they collect it immediately, the tube, they have to test this within 15 minutes. Within 15 minutes, this test has to be done and the results has to be released. But till the time it goes to the lab, it has to be on ice. This is a very important question when it comes to MLPOW because this is something exception. Which tube you collect, why you collect, how you transport, what they are looking for. 4 or 5 questions and 1 sentence, done. And to see that ammonia, they don't take the venous blood, they take the arterial blood because only oxygen has to be taken, not the ammonia or more of carbon dioxide through the arterial blood because it's a pure blood. If there is something wrong, if the doctor suspects something is not right, then this is done under stat. Okay. This is also used to check the blood pressure. That's another thing. Look at the picture, how they insert. So to put the arterial line where they're inserting in the radial artery. This is a good source. Look how they are inserting. And why do you think they have to insert? It's okay, miss, why don't we take usually even for the arterial puncture, we don't do the arterial puncture. The special people who are there as the respiratologist will recommend a technician to do the job. We won't do that. The special technicians who work under respiratologist to find the blood gases, like how they are functioning, what's happening, all those things. We don't do that. As a respiratory technician will do the job, not the phlebotomist. That's one thing you have to know. So but you should know, this I told you, this whole module, this unit, not the module. This unit is mainly to have more knowledge about the different pokings, puncturing, and the devices that we are using to see different things. It's not for you. Why we are learning this? To know that this is not our business. We can have information about this, but this is not our business. Arterial line. Maybe used to collect blood gases in other specimens. Maybe used to administer meds. Dopamine is given. So this dopamine has to go only through the arteries immediately. What is dopamine? Any idea?
Is the happy hormone?
The happy hormone, mainly for more depressed patients. Sometimes the digoxin is given because to save the heart. So these are the different conditions that they know what to do. Never put on a tourniquet or do a venipuncture on an arm with an arterial line. Now, this is the information for you. This is what you have to know. You don't have to know how you insert the arteries and how you're going to perform the arterial puncture. That's not a business. Of course, we have to know there is a puncture called the arterial line, right? Or arterial puncture. It exists. You have to know. Yes, we know. Now, what is your job as a technician? They're putting it in red. This is your job. What is your job as a technician?
Do
Never
not
put on a
collect from the
tourniquet
arterial
Never
line.
put a tourniquet or
or
do a
do a
venipuncture.
venipuncture on arm.
This is what you have to know. This is what we are concerned about. Clear? Now,
Yeah.
next. Dialysis, this is a procedure that's done where? To who?
In the hospital for people with sick kidneys.
Diabetic
Diabetics. Kidneys have been affected. It's not functioning properly.
kidney.
Then there
Yeah.
is a procedure.
Yeah.
They will
And
insert the
state
device
of
and then they will just flush out the toxins from the body and everything. Okay, hemodialysis is done through the blood. Dialysis done through the blood or vascular access is a way. That's been we get the fluid or the urine that's been collected has to be uh, brought out. Why? There will be a chances of infection or contamination, so this has to be done. Now, how they do this? This is again for a knowledge. We are not going to do this. Access allows blood to travel through soft tubing to the dialysis machine. So there'll be a dialysis machine that will be here inside your body. And they have this in a body, it's a small thing, and it'll be filtered. There'll be a dialyzer, and then it's taken out. So we're talking about the devices. So the device is inside. This device will be inside the body. And it's done by a minor surgery. They put the device there. How they will remove this by arteriovenous. Now, this is where you get the combination of two words. I told you inter. Inter means two, which means the artery and the venous both are being connected with some tubing. We call the fistula, or they will cut it and insert both of them. They attach together like this by inserting a device here. So in one way, both will be purified. Both veins and the arteries which are collecting the filtered waste will be taken into account, and then they will be just removing the fluid. I don't have much idea about this, but I have seen this. Of course, we don't perform, so you don't have to worry about it. Just to know this is a device is existing there in the patient. So avoid collecting from the arm with a graft. Now, this is what we have to know. This one, last point. Don't collect the blood from the arm with a graft or fistula to reduce the risk of infection or unnecessary harm to the patient. So they will tell you when you are working as a technician, phlebotomist in a hospital, you will get everything, the information. The nurse will inform you. There is this one, this is this one, you cannot touch this. If the nurse is not there, look at the document. There'll be a chart hanging. This patient with this complaints is there, this has been done, so they will write the information. So when you enter to collect the blood, if you have the document or not here in your hand, it will be there in the chart. You have to make sure as the nurse and then do the procedure. Double checking. Arteriovenous fistula, this is how it is. Look at this, where they are performing in the wrist area, an access site formed by joining the vein and an artery in the patient arm. There'll be a device that they insert to do the cleansing of the what do you call the body fluid, used for an in-center or home hemodialysis. Even this can be attached when the patient is at home, or if they are in previous, I am talking about 10 years, 15 years ago, for dialysis, they have to go to the hospital or a clinic. But now they have attached it, and then the patient can perform even at home. Now look how it's looking like the graft. I mean, whatever they have inserted, the tubing, these are all permanent. An access site formed by a piece of soft tubing. So this is where, look how they have connected. There's an artery, there's a vein, and there is a graft. It's like in the form of a tubing, they attach it, right? And look how bulgy the hand is. We are not going to collect the blood from this hand if you're working there. It's a big no, no, no. Why? Asinat, why?
Because it reduce you don't do any collection from the graft to reduce the risk of infection
Very good.
unnecessary to harm the patient.
Yes, very good. Good job.
Mm.
So these devices are central vascular access devices. What do you mean by central vascular access devices? This is attached closely to the in the chest area. Maybe this is a central one. The peripheral one is other than the chest and the abdomen. The peripheral devices will be on the hand or the legs. It's a different thing. But when we talk about the CVAD, this is you may get a question sometimes based on the abbreviation. What is a CVAD? So you have to know this. But this is not that important because you're not going to perform anything. You have to know. It's a knowledge based. Also called indwelling lines, tubing inserted to the main vein or artery. There's a superior vena cava or the aorta, wherever. Primarily for administering fluids, medications, to monitor the blood pressure and drawing the blood, everything. But this all connected with the tubing system. It extends up to the hand. You can collect it. Or they have specific sites where you can collect it. Used for patients who need IV access for an extended time. When they want to do when the patient is there, for example, it could be a cancer patient, to my understanding, a patient with which is having the immune deficiency, could be an AIDS patient or could be a burnt patient. They want some prolonged treatment for up to 1 month or 2 months. They are there, then they have to use this device. This much you have to know. And especially useful for patient without easily accessible veins. This is another condition. If the veins are no good, they have to perform something different, so they use it. Routinely flushed with heparin, as we have already talked about the saline and heparin, why we are doing this, to prevent the blood clot. That's a thrombosis. And what will happen if there is a clot? This clot may travel inside the blood vessel and then the patient will die. Because if it reaches the heart, if it reaches the brain, immediate death. That's called the embolus. So we don't want those conditions to happen in a patient's body. That's why they are flushing it to avoid the thrombosis, which is the clot formation. Remember one thing, clot formation is a very critical condition where the patient can die immediately. It bursts. The, the clot goes there, and then it will sometimes, when the block is a little bit bigger, it will just block something, block the passage, and there will be a condition where there's no blood supply, and then they will die. So this is a condition. 2 times the amount of dead space must be drawn and discarded before blood collection. So, for example, you have to draw more blood, in this case, in a discarded tube, and then you have to throw, and then you collect the blood for the results. So these are all some critical steps that's involved with more critical patients who needs more care, who needs more, what do you call, monitoring. Usually we don't do this. Nurses, they are trained. I told you some nurses are there in the hospitals. They have certifications, extra training, extra experience. Only they will be allowed to do this job. In case, if you are there, they will train you. I told you for 6 months, 1 year period, they train you. They don't tell you all of a sudden go there and collect the blood. 6 times the dead space, about 5 ml for coagulation test has to be drawn. So this is based on the test, based on the demands of the test to see by the doctors. They will tell you what need to be collected, what they want to see. So based on that, the specialists who are there, they will use the tubes. And first they use the discard tube to discard 5 ml, 2 ml, 1 ml, depending on the test. They throw and they collect the blood. Why they are doing this? Because if the tubing is like cleaned with heparin, then the test results in the blue tube will be affected because we are looking for coagulation. That's why we have to collect 5 ml of at least blood and throw it, because when we're using the heparin to clean, there may be some deposits or remnants inside the tubing. If you are going to collect the blood without discarding, that heparin may interfere with the coagulation factors. Something will be elevated, something will be lowered, and the doctor might be thinking based on the results, okay, this patient has some serious issue with clotting, and again, they will start giving them the medication that the patient doesn't even need it at that time. They don't want it. But because of some errors, this can happen. That's why they want to make sure. First, they will document. People who do the flushing through the heparin will document. And people, if they have to collect the blood in the blue tube, mainly to see the coagulation factors, they will look for it automatically. They will draw 5 ml of the blood and then they will throw it out. And then only they will do the procedure in the blue tube. This is to be safe. And the patient shouldn't be getting the false results. And 3 types of CVADs. Once in that CVAD, we know what a CVAD is. In that CVAD, now we have 3 types: central venous line, implanted port, there's something settling inside, and peripherally inserted central catheter. This is a catheter that is administered other than the chest or abdomen in the other sides of the body. When we talk about the central venous line, it's close to it's in the chest. We have diagrams. I will show that to you. This is how it is. Central venous catheter. So it has to connect with the vein and artery that's here from the jaw area. That's the internal jugular, and the vein access site they have inserted here, the jugular vein. This is called the jugular vein. Okay. And then from there, there's a minor surgery that they have to perform to insert this, which is close to the heart here at the top. So that's why it's called central. Can you see this? Usually they put it in the, because we are collecting the venous blood, it's towards the right side. Why? Because the right side blood is entering the, not, yes, all the impure blood that's been collected by the superior vena cava is entering here in the right side. So they have to put it there to collect the blood. Can you see? Let's look at the picture.
Can you enlarge it, ma'am? Thank you.
Enlarge?
Yes, just a little bit.
1 second. Is it clear now?
It's
I'm
gone
trying.
smaller. Sorry.
Very small. 1 second.
Gone small. Yes, it's smaller now.
I'll try to do that at the end, because if I do that, I may lose it.
It's okay, ma'am. What is that red line below? Below the
There?
breast? Yeah, what's that? What's that? We
This
can
one.
access actually. Yes.
External.
This is where the external limbs of catheter, which means they can
Okay,
collect
thank you.
the venous blood or the arterial blood. That's why they have put it there.
I've seen one in the hospital actually, the central venous line.
No, actually, this is for the vein. You cannot collect the arterial one, but it's for the mainly. They have shown a picture from the dialysis patient.
Yeah. The central line. It's called the central line.
Yes, central line.
The
It's for the
venous,
dialysis patient. So in the central venous catheter, there'll be a large vein because it's like a often subclavian vein. It's a large vein advanced into superior vena cava. I told you all the venous blood is collected, goes to a bigger major vessel, a big vessel. So they put it close to the right arm. To the right atrium, which means close to the heart, the right hand side. Why we are doing this? It's a good source of venous blood flow. And it will be under the skin. they will be stitching this under the skin because they want to make that it's firm, it's there, because they can use it whenever they want to take the blood. Okay. Well, they say there's a transparent dressing because they don't want to make them show the tube outside. So there's something with the skin color that's actually on top. Why the others cannot see, even the patient doesn't have to feel something like that, like a tubing attached. They'll get used to, they have no choice. Depending on the condition, what they're going through, all of them will be mentally prepared. Because if they don't do this, the patient's life cannot be saved. So they all know that there's something important that they have to deal with it. Of course, the procedure is going to be a little bit, they perform a minor surgery, so it will take time. But after that, they will tell them what they can do, what they cannot do, how to take care, everything. This is better than poking again and again or doing some procedure every time. This is one time attached and they can do the procedure, which is a better way for the patients to feel relaxed because they have no choice. What is an implanted port? Look at this. This is something left under the skin, like a small device. This is called the implanted port. It's a small chamber under the skin attached to the indwelling line, which means attached to the line inside the tubing. Located in the upper chest or arm, and is located by palpation, where they can palpate the heart, they will put it. What's the reason? Reason, once again, to insert the catheter. Catheter is a special device where they want to take the venous blood, perform the dialysis, they can use it. Look at this. It's under the skin. They stitch it. They will make a minor incision, they will keep the device and then they stitch it. They have to insert the needle and get the blood at that port. That's it. So these are all a little bit painful, right? You call
Yes, it
this
is.
highly invasive procedures.
Yeah.
And then PICC, this is another thing, line inserted into peripheral vein, the antecubital. This is what the IV line that we usually get when people go to the hospital for some dehydration issues. Uh, they just go, then they insert it as in the here in the antecubital in the hand area. Because this is not associated closely to the chest, we call this peripheral, which means surrounding the body. Okay. And never apply a tourniquet to do a venipuncture above the PICC line. This is again something that they are telling us we have to follow. This message is for us. This is a message that we have to take into consideration. Never apply a tourniquet or do a venipuncture above the line. Okay, why? Because if we do this, it can damage the line by pressure or puncture. You will get a question based on this. What is PICC? We know. Peripheral. What is PICC?
Peripherally
Peripheral
inserted
inserted
central
Central
catheter.
catheter, you should know. What you have to do as a technician, never apply a tourniquet or do a venipuncture above the PICC line because you may damage the line by pressure or puncture. Now, this is the one that they are talking about. This is the one that usually we have seen in patients when they are admitted in the hospital. The above two conditions are specialized conditions where people are with different situations, different ailments, mainly diabetic hemodialysis has to be performed. In that, we have the imported the device like inside the body. This is the one. I'm talking about the bulgy implanted port, sorry, central venous catheter like this. And this implanted port of a special condition where they have to walk to the hospital again and again to perform certain procedure to get the diagnosis properly, if it's working good or not, maybe some medication, or if it's a diabetic patient or the kidney failure patients, or the kidneys are not functioning properly, they will go there, not failure. Failure means it's death. Something has to be done. Kidney transplant has to be done. So it's partially working conditions of the kidneys where they need the critical treatment. Then every time they have to take the venous blood, everything, every time there has to be a dialysis, they use this implanted port or CVCC. But generally, we have seen this. This is common, peripherally inserted, because in the hands, they may insert this IV line, and we have to follow the procedure. Now, question time. Anything you want to know? Now, how it's connected to the heart, the one that we do in the hand, how it is connected to the heart, the diagram is there. When we just do this, it automatically is connected to the heart, the line. So this is the IV line that we are familiar with to draw the blood, venous blood. Any questions? But I can ask you so many questions. This is for the special hospital situations, but if you have more to know, you can ask Monmon. She's also going to say the same because she's not allowed to touch these things, but she has witnessed more than me. Maybe she can give you some tips, but you don't have to just know everything in detail, just to know what is an IV, what are the other devices that you have to know as a technician if you're there, and what are the don'ts that you have to follow and why. And mainly look for the source of information when you attend the patient. What is the condition of the patient? How you have to collect the blood. These are the important focusing points. Just go through the slides once again for 10 minutes. I'll be asking questions. After that, you can go for a break. Then after the break, we have to watch a video. Wait, we have to watch a video. Once again. I'm sharing this screen, guys. No.
Hey everyone, Dennis Ernst here. What's one of the biggest problems in drawing blood from an IV device? Yep, hemolysis. See that sample? The lab can't test that. It's got to be rejected and redrawn by venipuncture. No phlebotomist or nurse has time for that, and no patient or their physician wants lab results to be delayed by a redraw. In this video, I'm going to tell you how you can prevent hemolyzing blood samples when you draw blood from a line. If you're a phlebotomist who doesn't currently draw from a line, stick around. You may not now, but later on in this video, I'll explain why I think you will be soon. Oh, and don't forget to subscribe to this channel right here in the corner and click on the notifications icon to our homepage. First, where in the hospital are samples hemolyzed more than anywhere else? Well, the emergency department, right? Look at this. One study found samples drawn by laboratory phlebotomists are hemolyzed 1.6% of the time, but when drawn by emergency department personnel, it's 0%. Other studies say it's 25%. A 25% failure rate might be acceptable in some industries, but not healthcare. Why is it so high? Because so many patients in the emergency department get IV needles put into their arms, and before the nurse starts the fluids, they draw off the blood samples and send them to the lab. Why is that problematic? Well, think about it. IVs are designed primarily to infuse fluids, right? Not withdraw blood. Some are more red cell friendly than others, but if they were all designed to draw blood, well, we wouldn't be seeing such high hemolysis rates, would we? Yet we do. We have to remember red blood cells are like fragile crystal orbs. And if we don't draw blood samples with a device designed for it, well, it's going to likely be hemolyzed. So the first thing you can do to prevent hemolysis from a line draw is don't draw from a line. Unless you're using technology designed for it, do a venipuncture instead. Hey, if 25% of your line draws get rejected by the lab, why subject that many patients and their physicians to the delays in getting actionable results? You either implement the technology or you limit line draws. The second strategy is, if you must draw, limit it to large gauge cannulas. Look at these statistics. To the gauge number, the smaller the diameter, right? So if you through large diameter IV sets, 14s and 16s, you're not likely to end up with a hemolyzed sample as long as you do everything else right. But draw from 18 and 20 gauge IV lines and your rate of hemolysis is 3 to 5 times that of a routine venipuncture, with about 3%. 22 gauge or larger virtually guarantees hemolysis. So if you limit draws to 14 and 16 gauge cannulas, you'll probably be okay. The problem is, though, most IVs are 18 or 20 gauge, so you need the right technology. Also, if you must do a line draw without devices designed for the purpose, use a tube holder and draw directly into the tube instead of a syringe. Most people pull way too hard on a syringe. Besides, the vacuum in a tube is limited. And when it comes to those fragile crystal orbs, the less negative, better. Those three things will eliminate a lot of hemolyzed samples and recollects. Caveat, you can try and see how it works out, but notice how each of these is behavioral. They each are dependent upon the nurse making the right decisions. That's not only hard to implement facility-wide and especially system-wide, it's even harder to maintain over time. And you usually end up with this graph where your hemolysis rates rise when people drift back to their old habits and then fall right after a reminder, only to drift back up and down, up and down. Or you can implement technology designed for drawing from peripheral lines like this. After the line is flushed, this device attaches to the lure of the IV set. Flexible internal flow tube is advanced through the cannula beyond the catheter tip where hemolysis usually occurs, and to a point where the blood flow is more normal. Then the collector simply withdraws the sample as for any other draw. Once the tubes are filled, the device is removed and the line is flushed again. Samples drawn with this device have been found to reduce the frequency of hemolysis by up to 56%. A term you're going to be hearing more and more is one-stick hospitalization, because for patients who have peripheral IVs, blood samples have far greater success and with significantly less hemolysis than without them. Better yet, it's much more comfortable to the patient who doesn't have to be stuck up to 5 times every day. This particular device is called PIVO from Volano Vascular. It's already in use in many facilities, reducing from patients with peripheral IV lines, potentially for their hospital stay. If you're, I think it's one of the most promising developments of your professional career because this is a device you can be trained to use. That includes flushing the lines. The only time a nurse would need to be involved is to discontinue the fluids and then again after the blood has been obtained. Is a flush solution a medication or a device? Well, the FDA does not consider a saline flush to be a medication. They consider it to be a device. Same for the Joint Commission and the pharmaceutical industry. So teaching a phlebotomist to flush a line with saline is perfectly acceptable, at least in the US. A lot of people think phlebotomists can't flush a line and that it's the same as administering a medication, but that's a myth. It is entirely acceptable. Because of that and many other reasons, this technology is well on its way to changing the way blood is drawn. Aren't something we have to avoid anymore, and there are samples that are bound to be rejected for hemolysis. So how about that? Suddenly, phlebotomists are of much greater value to the nursing profession, to the lab, and to the patient. If you acquire this skill, your stock goes up, and it's about time. As more and more facilities adopt one-stick hospitalization, more and more phlebotomists are going to be trained how to draw from a line. That's good for you and good for the profession. That's it for now. Thanks for watching. Subscribe, and remember, keep sticking to the standards. See you next time.
Guys, questions? Me asking questions, okay? I am asking questions now. So what he said, is syringe method okay to draw the blood if there is an IV? Any idea? He showed the diagram. It's not a good idea because you may sometimes pull it harder, so the blood can come with more pressure. So there should be little pressure. So tube is the best solution, according to him, right?
Yes, miss.
Okay. Direct tube
Yes.
method. We have seen that. He explained the cannula. Cannula is the thing that's inserted to get the blood, like if there is an IV. So how it enters inside the body, the system, how the blood is drawn. We have seen the picture. Okay, he said it's the best method. And he talked about to avoid the hemolysis, what is the gauge that is used? Is 80 okay? 18, 20, 22 okay?
Well, there is a chance of hemolysis. Sorry about
Hemolysis.
that. Well, yeah.
Okay, no
It
problem.
was,
So which
14 to
gauge is
16.
14 to 16?
14.
Yes.
14, 16. So he explained the whole thing. But again,
That's
an
right.
added information that he said, now phlebotomists are getting the training to flush the IV line using the saline. Why we have, first of all, what is saline?
Normal salt solution.
Normal salt solution prepared under sterile condition.
Calcium chloride.
Yes. Why we have to
Yes.
flush the IV line?
To avoid any interference from the IV. Yeah.
The IV? Is that what?
Thrombosis.
Very good.
Right.
Very good. To prevent thrombosis, blood clot formation, and to keep away from infection. In other way, that both the things. But previously, nurses, they did the job. Now, who has been giving training? Who has been given training?
Technicians.
Now the technicians, the phlebotomists. And then he said few reasons why.
He said it is a device, not a medication. It's a device. So you are being trained to use a device. That's what I can remember.
Yeah. You've been trained to use a device. It should be considered as a device according to who?
CSLI.
FDA. Food
FDA,
and Drug
yeah,
Administration.
yeah.
Yes. Food and Drug Administration Association, something. In the US, at least in the US, he said. I don't know whether they are doing this here or not. But the only thing he said you have to call a nurse to do is to open and close. That's it. You're not touching that. But he said saline treatment or saline flushing is like a device. It's not a medication. So we can do that. So this information should be there. Is everyone okay? Clear? Let me start from the bottom now. Questions, welcome. So he said this is mainly for the emergency patients or patients who are getting the hospital treatment. You should know how to draw the blood, where to tie the tourniquet, and if it's a fistula, don't touch that hand. Why?
Prevention of infection, and it
Infection
might
or harm to the patient. Yes, very good.
Yes, harm
So
to the patient.
grafting is because it's, you can see the hand. It's something inside. It'll be bulgy. Something is visible, right? Even from the outside, it's visible that that's not right. So you don't touch that. Maybe you don't know how to handle, then it is a big harm to the patient. Okay. Why can't we take if we are collecting in case if you are trained, you're collecting the IV, like the blood from the IV line directly. You
Yes,
need to have
I can hardly hear you because you're I don't know what's happening.
okay, 1 second. Now clear? No? So there's something
It's
that's
clear for me, ma'am.
It's clear now, but you were echoing before.
oh, okay.
Oh,
I think someone has to mute. Yeah, I think yeah. When the others open, then it echoes. So yeah, if you are drawing the blood in the IV line directly, you have to use the discard tube. More blood has to be 2 ml has to be discarded. When it is a test for coagulation studies, then how much ml has to be drawn and discarded?
5 ml.
High ml has to be discarded. So these are the important exam questions that you may get. But again, it's a knowledge base. You won't get everything in detail. This much information you have to know. And mainly the one that is in red, you have to focus on those things because it will be exam questions. As I told you, yes, we are getting the information. It's a knowledge, but still we have to, the guarantee that we are studying this, we are focusing on this is the exams. We have to clear the exams. That's why I'm repeating this, how to focus, where to focus, what are the important things that you have to look for, right? And how to answer them. This is the repetition. I'm repeating this again because majority of you come in the class, sit here, you get the information, but when it comes to choosing the answers, majority of them are confused because they have to be very keen on reading the questions first and picking the right answer, what they're asking for. So from that point of view, yes, Azinet, go ahead.
For the exam, Miss, what unit are we focusing on? What are the
So
units?
it's a final exam, so everything totally.
Okay, thank you.
That's why what I did to avoid any situation where you feel like overwhelmed. Okay, how we're going to do the test? How we're going? I covered little bit with more information in advance, and I gave you the sheets in advance to prepare, to focus. And then even if next week Munmun is there, you will be in the lab focusing on whatever we have done, the phlebotomy. And even she may tell you to start with the yes or I don't know, because it has to go with the, as per the procedure, it has to go with the module. But I just demonstrated. I want you to learn that in little bit advance because once when you are with her, you have the confidence now to perform. You know what to do. So I took the initiative to just let you know how to do the hemoq, you know how to do the yes or no, just I'm talking. You have to talk. Yes or no, tell SB yes or yes or no. You know how to do the yes or no, but you have to see how you have to record. Let me ask the names. Alexia. So if you are not there, that's okay. You have an idea that this is how you have to perform. I think majority of them, they know how to do the ESR. They know how to do separate the serum and the plasma. That's for your midterm, even the midterm exam. This will be asked. And you know how to run the centrifuge. You know how to do the, what do you call the HCT. What is HCT?
hematocrit.
Hematocrit, very good. So for the hematocrit, in which tube you will collect the blood? Now, Evelyn, you're not answering. Some other capillary tube. How many tubes per patient you'll be collecting?
Two.
Two tubes. Why?
Balancing in the centrifuge.
What is the name of that centrifuge?
Microhematocrit.
For how many minutes you will run the centrifuge?
5
5
minutes.
minutes.
What is
5
the
minutes.
what is the RPM for that?
10,000.
10,000.
10 to 12,000.
10 to
Is
12,000.
the range?
Yes,
Is the
10 to
range?
12,000.
Yes. So you all know this. This is what I've been asking. No one is answering. You know how to perform these skills from the next module. I trained you for this. People who have missed, it's not a big deal. You will learn eventually from your friends. You get to know, but it'll be easy for you and Munmun to go for the next module. So she may expect these things. I'll update the information what we have done, but you focus on phlebotomy next week. You can focus on so capillary puncture also we have tried. I forgot about that. Capillary puncture with the microtainer, the toughest job.
Oh my God, that one is like an assignment, man.
It takes some ages to take.
That one is
See?
It takes a long
punishment.
time.
No, comparatively, now you know the value of venipuncture.
I know. I like venipuncture.
Yes.
It's my best friend.
Me too.
Yeah, now you know why we are focusing more on the venipuncture, why we have to be quiet, why we have to focus, because this is what we are going to do. We want to avoid the microtrainer anyways. Why? Because you know, practically.
Stressful.
Yeah. So these things, maybe she may tell you to do the hematocrit or whatever, but the thing is, when you start the module, you will do this and you will record it. Now, this is just a demonstration. You have done this. This is a practice. But when the practical comes with the module, you will start recording. Don't use whiteouts often in your skill books. When I come back, I shouldn't see more whiteouts patches there. I'm going to tell Munmun to hide the whiteout. And of course, the whiteout has to be there somewhere important. Where is the whiteout that we are going to apply now?
White out in the microhematocrit.
Hematocrit, when you collect the capillary bed, focus on the whiteouts, not
That's
in
the
the
one we should
skill,
keep in
not
mind.
in the skill books. No. When there is says evaluator, it means we, the teachers, have to sign. You don't sign. Now again, you're bringing the whiteout. Now I've seen last Friday, like, I'm sorry, there are more patches, small, cute patches of whatever the whiteout is. Don't use that. Ask her. Maybe if she has a confusion, when I come back, she's going to ask me so I can clarify, but don't use whiteouts. You know better than us now how to use the book.
Yes, miss.
Without errors. So stick to it. Again and again, when you do the venipuncture with successful or unsuccessful, document. Once when you document in the skill book, go for the formative, not the summative. Go to the formative and then document it and get it signed properly. Okay, if you leave it without the white patch, this is better. If you don't have any idea, I can come and I can carry on with that. I'll update Munmun with this. So any questions regarding this, guys? So focus on phlebotomy. If you need more practice, you don't even have to ask anyone. This is your right. So go to the artificial arms, pull the folder, keep it on the side, practice as much as you can to get the steady hand. But now at this stage, you shouldn't be shaky. No one has to remind you for, okay, open the tourniquet, open the tourniquet. No, no, no. It's a big no. Okay. Oh, the tube is inside. The tube is inside. No, no, no. You should know tourniquet. We know now what to do. Do it properly. I taught you with the alphabetical order, so you shouldn't make mistake in all these things. And now the extra thing, face contact. Right? Just you're pretending. Because you have to make this as a habit, people will look for it. So you're pretending. So do this next week. And when she wants to start with the module, she'll give instructions so you can do and document it. If it is regarding the module, document it. But what, miss, if we have only 3 spots there in the 3 columns there for the skill book, that's okay. You record 3 times. Then anyways, you have to practice the ESR and hematocrit because that's for your midterm, for your final exam practicum. So it's okay if you practice. It's no big deal. Clear, all of you? So next week, you will be busy in this way. Okay? And now the following week after, yes? Someone asked something.
No, ma'am. I said, okay, thank you.
You're most welcome. And the following week, you'll be online. In that online, there'll be a review session again. I believe definitely there should be a review. In that, particularly during that week, we have to do more revision. So even in that, I have made you like prepare in advance because in this family, even though we never touch the papers, that's okay. During the family day long weekend, I gave the papers for you to go through the information because this is for the final exam of the lab safety. So you have more time to prepare. So my goal is I give you in advance, you will prepare properly, you will put some effort and slowly you can go through without any rush and you'll all be perfect to do the exam. But I want train you to get good grades in the exam. That's my goal because many people, they come, they sit in the class for hours, they put their effort, able to pick the answers because of some reasons. I found that they are struggling, they have difficulties. So I want to go in detail in advance. And now you have an idea how to select the answers properly. Keep this in mind. I won't be here during your exam time. So perform well. When I come back, I have to hear like you are all amazing. Good, 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 good. Because not only it's for the college, it's for you to gain the confidence. Gaining confidence has been a difficult task nowadays. Not easy. Clear? So you will proceed with more confidence in the future in this course. So that's my goal. You have enough time, you have enough resources. And once again, today after the break, I'll complete the other specimen integrity. This is a known information to you or for us. Why? Because from tomorrow, we will start revising for the final exam. Test revision with the papers that I have given. We will go through that. And I will give you some important tips like regarding the final exam. For example, if you get questions in this, how to prepare. So it will be a complete revision. Throughout the module, whatever we have learned, it's a complete revision. But tomorrow, day after tomorrow, and on Friday, I will leave it on your own. I'll just come in the class. I'll say hi, hello. And then I will be just giving you like the information, like whatever we have learned, whatever we have revised. Even again, I'll give you more, actually not include time for you to go through that quietly in the class. So you don't have to like exactly interact with me. I'll be there for an hour. Then I will give ample time till the end to prepare on your own. Is it good for you? Do you feel happy? Enough happy?
Yes, Miss.
Yes, thank
Yes.
you.
Yes, you're most welcome.
Thank
Now
you.
go for a break. Okay, go for a break. We'll come back. We'll finish the other unit. Just whatever important things that we have to focus, I'll tell you. It's because it's going to be a repetition. And tomorrow we can do with revision in a very interactive way. Interactive revision. Have a nice break, guys. See you at 11:30. Okay?
Thank you, ma'am. See you
Thank
11:30.
you.
So
Thank
all
you.
of you, please, Alexia, I just want to make sure all the students are here when you come back exactly 11:30. Okay? Thank you so much. Have a nice break.
Still, we can't hear you, ma'am. Still cannot hear you. Nothing.
Hi, guys.
Hi, ma'am. We can hear you
Hello.
now.
Hello,
Yeah,
ma'am. We can
I
hear
am with
you.
the Teams, but
hear you.
in phone. So what I'm going to do, I don't know what happened to my power. There is an outage. So what we are going to do, we are going to revise here. Okay, I'll be seeing you. Will be in the class. So tomorrow we can see the other unit.
Okay, ma'am. Thank you.
Can you
Okay,
see me?
thank you.
Okay. Thank
Can
Yes,
you see me
we
now?
can
Just
hear
your,
you.
Yeah, this is the
Yeah.
best solution I can find because I have to wait. I
Okay.
think this
We don't
area
see you
has,
now.
yeah, this is
Wait
like a
there.
power
Yeah.
outage. It happened, but I don't know why. Maybe it's going to take a few minutes. Everything is fine, but I'm not getting the power. Everything is on. But maybe it has to do with the system or some other thing. I don't know. But tomorrow will be fine because I have to share the PowerPoint. But anyways, we have time. So today we can do the revision. So if you have any questions, you can come up with the questions we can answer. So how many students are there? Like, I just want to know. Alexia is there. So Alexia, Amina, Asinet, Christiana, Chris, Zarina Main, Eveline, Huda, Joanna, Kara, Lewis, Marlene. Yeah, Lewis is here. So we can do the revision. So take the papers that I have given it to you. Pull it out and then you can go through the information.
Okay, but we'll go through it. We're gonna revise it tomorrow.
No, today we'll go through the information that I have given. So tomorrow we
Oh.
will do the revision.
Okay, ma'am. Thank you.
But today, if you have any questions, I have given you the papers already. You said you never worked on it during the weekend.
Yeah.
So there's pretty much information. But tomorrow we will talk about it in detail because the safety, the lab safety, we have more questions
Okay.
we have to talk about.
Okay. Thank you.
Yeah. Do you have the papers with you?
Yes, ma'am.
Yes, ma'am. We have it.
Just go through the questions. You can see your PowerPoint, or if you have book, you can go through that and take the answers.
Okay, thank you.
You're most welcome.
Which one are we going to review first, ma'am? The LSSP or the phlebotomy?
The phlebotomy.
Okay, thank you.
I sent a message, but what about others? Are they there? Santiago? Shabana? They're not there. Alexia is there.
I'm here, ma'am. Shabana's here.
Shabana is here. Amina?
Yeah.
Is Amina there?
Yes, Amina is here.
Good. Asinet?
Yes, I'm here.
Christiana?
Yes, I'm here.
Chris?
Here.
Zarina Main?
Here, ma'am.
Eveline? Eveline?
Yes,
Lynn should
ma'am,
be
I'm
there.
here.
Yeah.
I'm
Huda?
here.
Huda?
I'm here, ma'am.
Joanna?
Here, mom.
Kara?
Here.
Lewis? Yes. Maris? Maris
Yes,
is
ma'am,
here.
I'm here. Yeah.
Rojatu?
Yes, I'm here. Can you hear me?
Yes. Santiago?
Hi, Miss.
Hi. Shabana is here. Good job.
Here,
Sorry for the inconvenience, guys. It never happened. For the first time.
No worries, ma'am. It's okay.
So which one you find it very hard, like while seeing the papers? I've given it for revision. Which one do you find it's really hard? Have you gone through the equipment? Have you gone
No,
through
ma'am,
the
not yet. Not
equipment?
yet.
So which one you want to focus first? The safety?
Let's phlebotomy, as you said, ma'am.
Oh, phlebotomy essentials, the second part,
Yeah.
right?
Yes.
Okay.
Yeah. Let's go through, ma'am, the prioritizing blood collection,
Okay.
because number one is the stat. I'm not sure about the emergency blood collection, if that will be second.
Mm-hmm. First is this, which one? For the, just give me, okay, part 2.
Yeah. part two.
Review what was covered in your first phlebotomy review that we are covering already, right?
Yes.
You have done that, everything. I think everyone should be thorough with the tubes.
Yeah.
Are we thorough with the tubes?
Yes.
Okay, so you know about the pale yellow tube, the red tube, the SST. We have seen everything in detail, right?
That's right.
This is the phlebotomy review that they are talking about in the first one.
The
So
audio draw.
yeah, what are the minimum identification steps required to properly identify? What are the minimum identification steps required to properly identify an outpatient? I want everyone to answer because this is like a revision. So please, an outpatient.
Outpatient is for the OHIP card, and the request.
Okay.
The steps are 6.
Yeah, from the doctor.
Okay, so this is from the doctor directly. No, the requisition you mean to say, Amina, requisition.
That's right, the requisition.
Okay. Inpatient, how will you identify the inpatient? I want everyone to answer, so please
So you
Shabana,
confirm
The
wristband
Or the wristband.
wristband.
on the person.
Intervention on the wrist.
So what will you confirm, basically, what you're looking for? The main
Last
thing.
name, first
Name,
name, date of
name,
birth.
date of
The last name and
date
first
of
name, date of birth.
and accession number.
Accession number, very good. It's an
Yes.
accession number, right?
Yep.
Okay. And a patient in emergency whose identity is unknown. This is something important. So what will you, like, how will you identify the patient?
You ask
The
the
patient is
should still
given
have a
an
number.
access number.
One at a time, please. It's echoing.
Speak to the charge nurse.
Charge nurse. And will you document it?
Yes.
Yes,
Yeah.
document.
We will document it. Very good. And then, so who will document it in this case?
We
The
will
nurse.
document that there is a
So the
Yeah.
nurse also will identify, and then they will tell, and then you will talk to the charge nurse. And when you're collecting the blood, she should be there with you. There was one question in the previous test. I think a couple of students made this mistake. I have to clarify this. If it's an unconscious patient, right? A nurse should be there. If an identity is unknown, then you have to confirm with the nurse. So in both the situations, you have to verify with the nurse, and you document it. Okay. Is it clear, that one?
Yes, ma'am, it's clear.
Yes.
Okay. So usually this situation happens in the hospital. So you have to follow the nurse. And discuss how should you prioritize your collection tasks. Yes? Yes, Kara. Sorry, Kara. Yes.
I have a question. Is Asenet?
I think Asenet.
Yeah. So in emergency, I understand that how you identify if the patient is an inpatient, right? And how do you identify? You can identify by the wristband or ask the charge nurse if the patient is inpatient.
Inpatient? You have to first look for the wristband.
The wristband?
If it is, yes, wristband. If it's not there, then you ask the charge nurse.
Ask the nurse.
Yes. And if the patient is in conscious condition, if it's not in the conscious state, then definitely you have to have a nurse by your side, because there is a PowerPoint which tells us that in case, what if the patient all of a sudden gains consciousness and he doesn't know what's happening? So, right, the situation may be hard for you and him. What if there is a reaction for the needle? So if the nurse is there, that's a witness, and there'll be a help for you as well.
Right. Thank you.
You're most welcome. Then the next one. Yes, Kara. I think Kara raised the hand. Kara, I want to hear from you. I see that you can put your hand down. Kara, any question? Okay. Is Kara not here? She wants to ask something. Okay. Discuss how you should prioritize your collection tasks related to each of the following collections. The page number is given for the phlebotomy textbook. The first one is STAT. What do you understand by STAT? I'm going to ask you.
Immediate.
Immediate. Who's that?
Mary's mom.
Immediate.
Short turnaround time.
Short turnaround
time. Very good. What does ASAP means?
As soon as possible.
As soon as possible. Okay. So what do you have to do in this situation if you're a technician? If you are a technician, what will you do?
It's not immediate. It's not an emergency situation, but you should not also delay it. So,
So
okay.
you can take your time. You can take
No,
little bit.
not that you would take your time, but the speed will not be so. You don't need to be so
rushing.
rushed. Yes, you don't need
But this is
to be
something
so rushed.
important that the doctor needs to see, right?
Yes.
Okay.
Yes.
What is fasting?
Not eating for.
Okay.
Not
now
eating or drinking.
Okay, I want to know from others. Lewis, what do you understand by the term fasting? Okay, very good. So what is the time? Is there any time limit for fasting? Santiago?
Yes.
Santiago?
Yes. Sorry.
Yes. What is the time limit for fasting if you want to draw the blood?
At least
It's
10
from
hours.
8 to 12.
I think it's 8 to 12 hours,
8 to
miss.
12
8
hours
to 12.
fasting.
8 to 12 hours of fasting. Very good. What if it's exceeding 12 hours? Like, for example, 12 to 16 hours? Yeah. So it means the test results won't be accurate, so you have to tell them to come the other day. That's one possibility you can do if it's exceeding 16 hours.
If it's exceeding 16 or 12?
Exceeding like 12 to 16 is okay. Still they collect, because I did once. I was like 15 hours late, but that's okay. She said okay. But usually we have to go for the next day if it's exceeding 16 hours or something. But usually the labs have their own standard operating procedures, so you have to verify with the lab. They will tell you what to do. So random, what do you understand by the term random?
Collected at any time of the day.
Collecting any time of the day. Very good.
And not necessarily to be fasting.
Yeah, that's an important thing. Yes,
Yeah.
good job. What is timed? Timed means?
Collect as a
An
specific
example
time.
would be like a glucose testing.
Glucose testing. Very good. A good
Yeah.
example. Glucose testing. Good job. Pre-op. What do you understand by pre-op?
Before an operation.
Before
Surgery.
an operation or surgery. Very good. So routine. What do you understand by the term routine?
Relating to established procedure.
Yeah.
Their
Related
lab
to
is standard
routine procedure. Usual
like
procedure. It's
that's
like a usual procedure.
Like example for collecting the CBC.
Yeah, you can go anytime. It's routine. They will collect it. Emerge. What is emerge?
Short for
Urgent.
emergency.
It's urgent.
Emergency. It's an
Emergency.
urgent situation. So these definitions are there in page 214 of your phlebotomy textbook. So go through that. Remember, we have started a revision, so we'll be doing daily. Okay. Discuss some key points. You have the papers with you, so please go through the fourth question. Discuss some key points on how to deal with children during specimen collection. What are some things that you should do and should not do? How will their specimens be affected if they are distraught and have been crying for a prolonged time? This you all know. Yes, Zarina Mine, go ahead.
So for the patient, especially children, we should not tell them that it will not hurt. We should tell them that it will hurt, just
Little
maybe
bit,
a
but
pinch, yeah. And also we should calm if they are crying to prevent the increase of the WBC in the test.
results will be altered. Very good. Good point. Yes, good job. Yes, Christiana, go ahead.
I think another thing to point out is that I think this is the time that you can get their help, the help of their parents. So
Parents, okay. What if the
it
parents are
depends on
giving a hard
age.
time? Like they are making the venipuncture hard on you, like asking too many questions. They're very anxious. So what do you have to do? The next step.
The
Tell
next
them
step you
to
can tell.
stay.
Just to just
Sorry.
Go ahead. What will
The
you
next
do?
step you tell them is that the doctor will report any results, and that you cannot really speak too much on behalf of the doctor's, results.
Okay.
And just try to comfort them, like calm them down and let them know that the doctor will talk to them, basically.
Yes, you can tell them.
You
But
can
before,
also let the can I, you
and
can
also
also
tell
have
them
the
to excuse
patient
you.
to sit on the outside.
outside, very good. Before collection, yes. This is before
Yes.
collection or during collection. If it's like bothering you, like you cannot focus, then you can politely tell them, can you please stay outside? Then what you have to do as a witness, you can call the other technician.
And
It's
call
been
the
mentioned in the slide. Yes, ask for help from another technician to be there with you, right?
Yes.
This is
ma'am.
what we have studied. Yes.
I think, Miss, it all
Good.
depends on the age, though, the age of the child.
Age of, yeah, the little bit older kids, they cooperate because they understand.
Yes.
The very little kids, they are very comfortable with if their parents are with them. So what
Yes.
they do, yeah, you can make them stay there.
Yeah.
It's all up to like how you handle it or how you feel it, basically in that environment. The next question goes to Kara. Discuss some key points on how to adapt for geriatric patients. What are some things you should and you should not do?
Geriatric and pediatric to me are kind of almost the same.
Very good.
You go in calm, depending on if they have vision issues, hearing issues, you would have to adjust yourself for that. So if they couldn't hear properly, just like adjust your tone, use your hands to show them like your tools, what you're there for, explain yourself, be patient.
Very good. Mainly be patient. Be patient.
Yes.
Give them the confidence that you are there for a good reason and you're there to help. Psychologically, they will cooperate. Very good. Good job. But what you should not do, you talked about more about the positive things, what you have to do, but what you shouldn't do.
Don't go in because they're elderly and start yelling and assuming that they're old or they have issues with hearing or seeing.
Yeah.
Just I'm not sure like what else I wouldn't do. Like I wouldn't with the same thing with a child, I wouldn't say it wouldn't hurt. I would discuss the procedure.
Yes, first ask permission. That's the first thing. They demand respect. So ask permission.
Right.
If they are in a room, like because mostly in the hospitals, you have to knock or you have to ask their permission. And then even before touching their hand, ask the permission. That's a consent that we'll be getting. And then you have to let them know that you're there to do a job, right?
Yes.
Yes. Okay, very good. So the next point, define needle phobia and describe how you should adapt your procedure in light of needle phobia. What if there is a needle phobia? Any other student? Thank you, Kara, for your information. The next one who's going to answer. Who is going to? Shabana, can you try? Oh, Rujiatu, go ahead. Good job. Come on. What if there is a needle phobia? You raised your hand, so go ahead. Okay, Shabana. Is Verna? Verna can try.
Yes.
Ma'am, I
Yeah,
can.
Okay.
okay, go ahead.
Who, mommy? Verna?
Yeah, okay, go ahead.
For the patient that has a venilophobia or called needle phobia, it is important to tell to the patient it's important to tell to the patient to start the poking, introduce the poking, to avoid them from getting any scared reaction for that.
So how will you tell them to just to be away from the needle? What will you do? Like
Like first introduce the procedure to them.
Then what if you're going to poke and then someone is having a needle phobia, but they are looking at that? What will you do?
Can I try?
Yes, go ahead.
Yeah. Instead of using the venipuncture like the big needle, like they can see. Instead, you can use the butterfly needle so they can see the needle because of their phobia. Yeah.
That's one thing. And you can tell them to turn the other way around or to distract them in order not to look at the needle. That's one
so
thing.
they can't look at the needle. Yeah.
They can't look at the needle, right? Okay.
So butterfly wing infusion is the one that you will use for those who have phobia, right? Right, Mom?
Phobia, but the thing is, you have to make sure you distract them. You bring it into some like different conversation where they are busy, they are engaged, right? So that's one way.
Distract them, right?
Yeah, distract them.
Okay.
Yes. So give them the confidence. This is not to hurt. This is for a reason that the doctor wants it. We have the requisition. It's for their benefit, for their health. Okay. Good job. So when collecting from inpatients, what are some things that you should do to ensure that you protect the patient's privacy and avoid embarrassing them? When collecting from inpatients, the seventh question, the first page. When collecting from inpatients, what are some things that you should do to ensure that you protect the patient's privacy and avoid making them feel bad?
Always make sure you announce, like show your presence. Don't just barge into their space.
Okay.
And then if you meet them in an awkward position, you don't need to bring attention to that. You go on professionally.
Yeah,
If they
professionalism.
are naked,
Yes, very good. Yes.
If they are naked, you maintain eye contact.
Very
What
good.
else? If they are using the washroom, you can tell them that you would come back.
Very good.
So
these are the points. Yes, very good.
I'm trying to remember other things.
Yeah, it's very good. Good job.
If they are asleep, you touch the bed and see if you can wake them up.
Yeah.
You don't touch them. You touch the bed gently.
Yes, very good.
You can wake them up. Yeah. And if they are with their physician, you can make a note to come back, because they don't always get to have their physicians around.
In the very good.
Yes. And another point is, if they have family and friends, if it is a start, you need to let them know that you need to take your draw. If you can do that while they are there, if not, you can tell them to excuse you. If not, then you can come back or something
and do
like
the
those
blood
sort of
collection.
points.
Yes, but if
you take notes.
Yeah, very good. Now to Christiana and Azinet, you want to say something?
Yes, miss. You can also knock before you enter the patient room.
Yeah, that's privacy. Yes.
Privacy.
Yes, very good. Then the next one. Any other thing? Christiana, you raised your hand. So can you please talk about it?
I was going to say lastly is that in case if let's say you get the patient's family members or friends outside waiting, it's very important not to disclose what kind of tests are being done because a lot of family members want to know
Interfere,
what's going on.
they want to
Yes,
interfere, they will ask, and then you have to be on the safe side as a technician because you don't want to give any information, right?
exactly.
So yeah, very
Yes.
good, they're good points, so you're doing good revision, all of you. The patient may ask you some questions while you're collecting the specimen. 8th question, give examples of some questions. For example, which you can answer within your scope of practice. You have to like assume some questions, you have to bring it out that questions, and then you have to make sure what you can answer, what you cannot answer, for which you should direct them back to the physician. So the patient may ask you some questions. Now you have to think about some questions while you're collecting the specimen. Give examples. Yes, Zeenat, you're ready. Go ahead.
For example, they will ask about the result, and then you direct them back to the doctor.
Very good. That's for B. Then that's for B.
Okay.
Right? Which you can answer within your scope of practice. Like, how will you tell this to the patient?
Like, will it hurt?
Very good.
Yes,
Very good. Yes. So, what do you have to say? No, not really. Is it okay to answer like that?
No.
No.
What will you say?
You have to say yes if it's for kids. You have to say that it hurts a little bit.
Very good. It hurts a
Yes.
little bit, but you'll come out of it. But definitely you'll come out of it. Very good. How should the, good job, guys. You're doing good. How should the phlebotomist respond and explain why, if or when the patient has thin, fragile skin which tears easily? How will you respond and explain? The patient has thin, fragile skin and it tears easily, it tears easily. So, what will you do as a phlebotomist?
So with that case, I believe there's no elasticity in the skin again. So you would have to pick an adaptive method.
Very good, adaptive method. But
Yeah.
if it is like a fragile skin, still you can do the venipuncture, but you can, the skin is fragile. Yeah, the fragile skin. They're
So you
talking
have to be
about the fragile.
extra careful.
Extra careful means, is there any option as a phlebotomist that you can use Azinet?
Yes, the butterfly.
Very good. Good job.
Butterfly. Okay.
You touched the right button. Very good. Because here says, not fragile vein. Look at this. How they are asking. The patient, this is what I want you to pay attention. Here they are telling you the patient has thin, fragile skin. They never put the vein. So this is how the tricky questions will be. Clear?
Yes, very tricky. Yes.
So yes, they mentioned fragile skin, which means you can use a butterfly. If it's a fragile vein, it means, and the second is they're giving which tears easily, which means it can rupture easily. The skin ruptures easily. So here in this case, go for a butterfly. What if it is a fragile vein? Then you go for the alternate methods. Okay? Clear?
Yes.
Good job. How should the phlebotomist respond and explain why, if or when is on blood thinners? What do you have to do if you are on blood thinners?
The phlebotomist will ask first in the beginning of the procedure if the patient is on blood thinners.
Yes, ma'am. And you will apply pressure in the vent site longer
More
to
than
bleeding stops.
To stop bleeding.
Yes, very good. Is everyone agreeing with it? Let me ask.
Yes.
Zenaida, do you agree with this? You have to ask about the blood thinners before the venipuncture?
Yes, ma'am. And you need to provide more cottons.
More cotton, very good.
Yeah.
So, Rujiatu, you have to say something. Go ahead. Okay, Yusra?
Yes, keep pressure for 15 minutes.
Very good. And then Ying Hong? Is it okay to ask about the blood thinners while doing the venipuncture?
Yes, trying the
Yes.
additional 15 minutes on the
Yes. Varna,
Yes,
agree?
agree.
Before the
Always ask.
venipuncture. Yeah,
Yes.
before the venipuncture, you just have to ask about it. Why?
Yeah, to avoid bleeding.
To avoid excessive bleeding.
Excess
So
bleeding.
yes, and in this case, you have to document sometimes because document
Yes.
it. And Shabana, do you agree with that?
Yes, ma'am, I agree.
Okay, Santiago, is it okay to provide 3 or 4 pieces of cotton to them, to these patients?
Sorry, miss, could you repeat the question again? You were cutting out.
It's about the blood thinners.
Okay.
How should the phlebotomist respond and explain why, if or when is on blood thinners? What will you do as a phlebotomy technician?
So if the patient is on blood thinners, you want to apply the cotton and you want to apply pressure for a longer period of time than you would normally with a healthy patient that's not on blood thinners, right?
Yeah, good. Good job. So who is actually doing the job here in case of blood thinners? What's happening? Any idea?
The patient is on anticoagulant.
What does that mean?
Platelets are involved. So it's something wrong with the platelets. Yes. Yeah. Yes, very good. And what if has prolonged bleeding after venipuncture? What will you do? How will you respond? Now this goes to
keep pressure. Oh.
Let me ask Maris. What will you do?
Ask to keep pressure, like to keep on putting pressure.
Yeah, very good. You have to keep on putting pressure. But is there anything extra that you have to talk about, Louis?
You're echoing. Who's echoing?
Because someone has to mute. Except the people who are answering, the others have to mute. So I think, Louis, can you respond? Who is this? Maris? Yes, Maris, go ahead. Is there anything extra that you have to do?
Yeah, ma'am. You keep pressing with the cotton to stop the bleeding, and then you're gonna check, and then in case you're just gonna put more cotton on it, and keep checking if still bleeding.
Yeah, and you keep them in the vicinity for longer. Like you don't tell them to go yet. You keep them in the vicinity.
Yeah.
And document it.
Document, yes.
Document. Very good.
Ask the patient, tell the patient not to take anything in their hands for a
Very
while.
good. Asinet,
like
I
2
was about
hours.
to mention this. This. Okay, you put pressure, everything, 15 minutes. Now they're going home. Now, on the way, if they lift something heavy, like even the bag, I told you, you have to tell them you cannot use that hand, right? Why?
Yes.
If it starts bleeding, they will blame you.
Right.
That's why we document it.
Yeah.
We document it. Very good. What if a patient faints? We have come across this so many times regarding the fainting patient. So I want Louis to talk. Louis. Fainting. Mm-hmm. 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 Very good. Good job. So we are all good.
But what do you do if the patient has never fainted and then they do faint?
That's why we have to. Yes, go ahead.
Stop the procedure right away.
Yeah, immediately release
That's right.
tourniquet and pull out the needle.
And put their head down.
Down. Why?
Yes.
Down.
Why? To
Yes.
make sure.
So
And
that the
another
blood
thing,
will circulate back.
circulate. Bring the ice pack. Where will you keep the ice pack?
At the back of the neck.
At the back of
freezer and at the back of the
the
neck.
back.
The neck.
Very good. Good job. So a patient complains of
also,
an yes, go ahead, Azinet, go ahead.
No, it's Kara. If the patient
Kara,
has
go.
already fainted, you can't put their head between their legs. So
No,
you would have to lay them down.
Lay down, yes.
Yes.
Yes, very good.
And
When
nurse,
he
in
feels
that
dizzy, when the patient feels dizzy, about to faint, then you do this procedure. As she said, if the patient faints, it doesn't know, like he's sliding, you cannot bring the head down, right? It's no point. So you have to gently make him sit in a relaxed position or make him lie down, and then you give the treatment. Yes, Kara, go ahead. You want to say something?
Yeah.
Yeah.
Yeah, I just had a quick. Yeah, I had to ask you something. So in this case, also you can ask your colleague, right, to be a witness or like.
Yes. To call them for help.
Okay.
Okay. And so you're all good in these things up to this. A patient complains of an electrical sensation during venipuncture. This is something tricky. Why a patient should complain about an electrical sensation here?
Because you have hit a nerve.
Because you hit a
You
nerve.
hit the nerve. There you
nerve.
go. Right
Yes.
away, you have hit the nerve. It means, there is an alertness now. You have to, what you have to do? You have to
Pull out
proceed
the
further.
needle.
Pull out the needle right away.
Immediately.
Pull out the needle immediately.
To avoid nerve injuries.
Yes. If the skin bubbles up around the needle, what do you have to do? This is something new. If the skin bubbles up around the needle, it means?
Is it a hematoma?
Hematoma. Okay. Hematoma. Very good. It's a possibility. And if the patient develops this red spots,
Petiche,
what do you have to do?
This
think that is not
this from the tourniquet. Yeah, you have to remove the tourniquet or
Remove
put
that.
the tourniquet properly so that it won't mark.
You can keep ice also, right? Because these are the
Yes.
blood spots because of the blood that's been drained outside in the tissue area. If the patient has a good job, if a patient has a bruise at the preferred collection site, what will you do? How will you respond?
Avoid it.
You cannot take
Yes, collect from other arms.
Other arms. Why? What's the reason?
Because of hemolysis.
First of all, it hurts.
It was
Cause of hemolysis.
Then
Hemolysis.
Okay.
And it can be
And it'll
painful.
be painful, right?
Yeah, painful. Good. Very good. Not only that, we have already talked about that if there is a hematoma, if you are touching that area, what will happen? Minute clot may enter inside the thing, and the test results may also be altered. Agree?
Agree.
Now I want to talk to Joanna. Joanna, do you agree with this?
Yes, ma'am.
Yes, because there will be hemolysis. That's another thing that we have talked about. Huda, do you agree about the hemolysis in the case of a hematoma and the small blood clot traveling? Very minute clot inside through the needle. If it gets inside the tube, then what will happen? Will the test results be good or not? It won't be good, right? The test results will be affected. Now, the next one. If a patient has a tattoo at the preferred collection site, can you collect the blood?
No.
If it's a fresh tattoo, avoid it. If it's a new one.
If a patient has a tattoo at the preferred collection, what if both the hands are having tattoos?
You just do it. Find your vein and do it.
That's what I want to say.
And you document it.
Not really. Not really. If the tattoo is fresh, there will be infection. So in that situation, if there is an infected tattoo or something is wrong with the skin, you cannot touch it. Otherwise, with tattoo, you can. And you don't have to document it. If you feel something is different, then you document it. I have taken blood from the tattooed hands. if it's a fresh tattoo, there's some sort of irritation in the skin where you visibly see something is not right, then you document it and then you don't draw the blood. Because it'll be prone to infection.
So it's better to take it from the other hand. But what if the other hand have a tattoo? What do you do?
That's what I'm telling.
You still do it.
Sorry, I didn't hear that part.
You still do it.
If you still do it, if it's like,
As long as no infection.
There's no infection, just a tattoo, but the tattoo is going to be there forever. So there's no point that you cannot. But if the tattoo is fresh, and the fresh tattoos may be prone to infection. So if there is something like an inflammation in the skin or something you feel it's not right, then you document it and then you don't draw the blood from that. Let the doctor know. They will tell some alternate methods or some other areas, like, for example, the capillary puncture. You can do that. Or you can tell them, you document it anyways, let the doctor know, and then they will communicate with them. And then after the treatment, when everything is fine, maybe they'll come again. But you don't touch the infection, the tattooed infection area.
Awesome. Okay, thanks.
Okay.
How about the pedicure? If it's fresh, you mean like if it's done on the same day, or it's fresh, has been with only 1 week for
It depends on the individual skin condition. You will see that visibly, it will be clear. On the same day, no one is going to go early in the morning like to do the tattoo. I don't think the stores are open before 9 o'clock, but they have to come for the fasting before. So clearly you can draw the blood. If it's the next day, if there is something fishy,
next day, like,
yes. In that situation, yes, you document it and let the doctor know, and they will tell you what to do. Or they will talk to the patient. Anyways, if it's an infection, inflammation, there's something redness, then they have to go to the doctor, and then definitely you're not going to draw the blood from them. Okay?
Okay.
What if
Miss,
yes.
how about the pedicure?
Pedicure, you can draw. That's okay, because the pedicure is going to be somewhere in the tourniquet area or even close to the venipuncture area, but that's not a serious issue. You can still draw the blood. This is an important question. You may get the question like this: what if there is a pedicure, like you can draw the blood, or will it be hemolyzed blood? No, it's a clear blood, but the skin shows some irritation or something like a visible sign that the blood has been drained there in the tissue area a little bit, but it's not a big deal. It won't affect the vein. You can still draw the blood.
Okay, so documented it.
No, we don't even document. No.
Okay, we don't need.
But give the eyes to them so that it'll be fine. Other than that, you don't have to do anything.
Okay, thank you.
Yes, very good. It's there in the PowerPoint. It's there in the PowerPoint. The patients. Yes, who's next?
Well, I just want to ask one question. Just want to clarify something. What if you were asked to fast like 24 hours before the blood, and then you did not fast, and then you still went ahead to do the blood? Is the result going to be accurate, or?
Can you repeat, please? Sorry.
What if the test you were told to fast before drawing the blood? And you did not fast, like, or you feel like, oh no, I don't want to fast, and then you still went ahead and do it. Is the result going to be accurate or not?
No, they are looking for something, and then that's why they're telling you for the fasting. For example, glucose. If you're eating and then going, it means your test results will be high because you ate already. The glucose levels will be high. So if it says fasting, and if the patient is not fasting, document it, and then tell the patient to come the next day. Or you can tell this to the supervisor, and then as per the lab protocol, definitely they're going to tell to come the next day.
No. Okay.
Fasting is fasting. They are looking for some lipids. You have to fast. And then for the glucose, you have to fast. These are the critical tests. You have to maintain fasting. That's it.
Okay. Thank you.
Yeah. What if the patient's arm is paralyzed?
You don't draw from the paralyzed.
The other side.
Go to the other affected side. Yeah.
Very good. Very good. Yes.
But if you have to draw, if you have no other option, you have to document, or you have to complain first that that's the case. And if you have to draw, then you document.
This happened to my mom before when she had a mild stroke. The doctor or the nurse cannot get draw blood into the
they
other
cannot draw.
side.
Yeah.
Yeah, so they get a blood or put injection and IV into the unaffected one.
Yes, and they will draw only from that. You won't get the blood if you get it. I don't think it's there in the PowerPoint slides. We talked about it. You have to go for a healthy hand, if not the skin puncture or from some other area. Okay, so the patient has had a mastectomy. This is another thing that we have to talk about. Who is going to answer my question? Chris or Zerenamine? Anyone can try.
Hi.
Yes, Chris,
So
go ahead.
for the mastectomy, you should draw blood from the other side, from where in the mastectomy was undergone. Yeah. And if both of the sides have been done the procedure, you should ask the doctor wherein you can get the blood.
Prioritize the test and then you can collect it using the which puncture?
Capillary puncture.
Capillary puncture. Why? Why we are so particular about this? Dynamite? Why we are so particular about the mastectomy? Why can't we draw the blood? Why can't?
It has the what do you call this? The fluid.
It can impair lymph flow.
Yeah.
Yes.
It can cause the infection.
Then
Yes, in the
arm
yes,
will
very
swell. The arm will swell and prone to infection.
Yeah, very good.
Impair the lymph flow, make the arm swell. Swell.
Yeah, because of lymph nodes
lead to infection.
removed.
Due to infection. Yes, very good.
Good
Most
likely the lymph node has been removed. And because the lymph nodes, they are more prone to infection.
More prone to infection. Yes, very good. So now, define the correct angle. So 9 questions we have covered, right? You have the paper with you. The 10th question. Define the correct angle of entry for needle insertion in the antecubital fossa. Huda, are you there? Can you try this question? Define the correct angle of entry for needle insertion in the antecubital fossa. Huda. Okay, the next person, Alexia. Can you give the answer? Define the correct angle of entry for needle insertion in the antecubital fossa. This one question, I think we can go after this. Kara, go ahead.
The correct angle is between 15 and 30.
Yes, very good. Good. When would you use a steeper angle?
No.
The next, I'm asking you, when would you use a steeper angle?
A steeper? That would be on veins that are really deep, or if somebody is like morbidly obese and there's a lot of adipose tissue and you have to
yes, very
get
good.
a little deeper.
Little deeper, like a 35 degrees to 40 degrees. You can just go like this. Yeah, very good. When would you use a shallower angle?
When a vein is bulging and completely
visible. Is completely and clearly visible and big, right? Good job.
Yes.
For what location would you use an even lower angle, and what angle would you use?
That would be the hand.
Very
good. Very
thin. Good job. Good job. The hand. Less than 15 degrees. Yes, very good.
I would
10
do
degrees.
Less than 15. Yeah.
Yes. What are the consequences of entering too steeply for vein depth? What's the reason? Why we have to go too
You go
deep?
through the vein.
You have to pass through all
Yes.
this disturbances and hurdles, and then the needle has to hit the vein. That's the reason, right? It has to enter the lumen of the vein. That's why it has to cross all the hurdles. That's why we want to make sure we don't miss the puncture. What are the consequences of an entry that is too shallow for vein depth?
To be on the border.
Above. So if it's too shallow,
Border.
you go above, superficial.
So what are the consequences of an entry that is too shallow for vein depth? If
You
you're
can
just going very
You
shallow,
won't penetrate the vein.
it won't
Be at the
penetrate the
border.
vein. Very good. It
And
will be
be at the
almost
border.
parallel to the skin or the vein, so you won't get the blood. That's it. Right? You
Yeah.
won't get the blood. So any other question? And this is an easy question, guys. We can finish this. So these are all the good points that we talked about. The correct angle of entry and everything. What are the things that we talked about? These are all really good. Now, what is the purpose of the tourniquet and where should it be applied? So Huda is not here. So I'm taking the question from Alexia. Can you tell me what is the purpose of the tourniquet and where should it be applied? Someone is raising the hand. Yes, Huda, tell me.
Sorry, I went to the bathroom. You said you
That's
called
okay.
me?
No, that's okay. I want to know what is the purpose of the tourniquet and where should it be applied?
Above the
You
arm.
leave above, like 3 to 4 inches above where you would puncture.
Mm-hmm.
And
What's
the purpose,
okay, the apply. Okay, very good. Purpose?
purpose would be to help find the vein and to help palpate it.
Mm-hmm. Very good. To hold the blood and then so that when you insert the needle, the flow should be good and you won't miss the vein.
Yeah.
Clear? Okay. Good job, guys. You're all good. I appreciate it. So a phlebotomist has uncapped the needle and is ready to poke. List some reasons why he or she may have to shield and discard the needle and get a new needle before collection proceeds. Lewis, I want you to attend this question. 12th question. A phlebotomist has uncapped the needle and is ready to poke. List some reasons. Lewis, are you there? So, what will you do? Why you have to discard? They are giving even the reason why you have to discard it. Oh my God. Okay. Reason is contamination. That's the exact touching point, right? Immediately. Yes. Good job. I appreciate this. Yeah.
Miss,
Yes, Azinet.
injury.
Hmm.
What about injury? It's you got to discard it right away because to prevent injury.
Yes, to prevent.
To prevent injury, yes. He said that. He mentioned
Oh, he
that
did.
about the
Okay,
safety.
sorry.
He never used the word injury, but he said it's like a
Sorry, I
to,
didn't hear
no,
that.
it's safety. He said
For
safety.
safety.
He said
Yes,
safety.
sorry, I didn't hear that. Sorry.
That's okay. That's okay. And so this is a good revision, guys. You all know the information here and there you bring out. Like, I really appreciate it. You guys are good. So, okay, now this is one more question. I'll stop. It's interesting. How many times maximum should you poke a patient whose veins you are having trouble locating before you call in another phlebotomist? This is an MLPAP question, by the way.
Two times.
Two times. So all know 2 times. I've announced this so many times. By law, I said even by law, right? By law, 2 times. How many times in total should a combination of phlebotomists attempt a patient at one sitting? This is tricky. How many times in total?
4?
4. Yes. 2 hands or 2. Yes.
Yes.
That's it. That's it. Okay, we'll stop with this. And then any other questions? Sorry for the inconvenience, guys. I tried my best, but this happened. So
It's okay, miss.
no, but I appreciate that you guys are there. You're cooperative. So I hope you enjoyed the revision anyways.
Yes, we did.
Yes.
Thank you.
Very much.
Thank you, Miss. I really enjoyed. But I just have a question or comments.
Yes.
It's not like we do not know the answer. I think it's how it's been like how it's been written, like how it's been, like sometimes you have to read a question over and over again to get but it's just that the way how it's stated, it kind of throw you off. I don't know why they do that.
This is like a tricky
They just
thing.
make it confusing.
Confusing, yes.
For no reason.
For no reason. For no reason. As the question can be direct, okay, I understand how many pokes. But the other way of asking, how many times in total should a combination, this is something that you have to put your critical thinking skills. Because you're performing a job which is like really, really comes under the Controlled Act, and you're just piercing something under the, on the skin, and it enters under the skin, actually. I'm right. So here you have to apply your knowledge and whatever you have studied, and you have to think now. Now it's your responsibility. That's why they are asking the tricky questions, so that now you will gain some experience if you get this type of questions instead of the direct ones. You will know the limit now. Okay, how many times we can poke, but what will be the total poke? This is why they ask these type of questions. So how you answer, for example, I told you one example of the IV, shutting down the IV. I told you my example. Took 2 minutes, at least 2 minutes. I even mentioned this to you. But in the question that I answered, it was 2 wasn't there. What should I do? The next closest one. This happens with the millimeter thickness in the case of heel puncture. 2.4 is the max, but 2 is there. 2.4 is nowhere to be seen. So there's no question. You don't have to worry about it. Go to the closest one. We talked about the ml, for example. The doctor wants to take 2 ml of blood for some 2 tests or something like that. Or your technologist is telling like collect 2 ml like this we need for performing 2 tests. And what is the calculation? How much ml of blood will you draw? What is the formula? 2 ml times?
I forget.
2.5. 2.5. So totally 5 ml you have to collect. But the 5 is nowhere to be seen. If it's there like 4.5 ml, go with it.
Miss, so going back to the sitting time. So in one sitting, say for instance, I am poking someone and I miss the 2, that's the only time I can do it. And then the next person who take over can do 2 more.
Yes.
That's what it is.
If
that's
that person is missing 1, then they have the chance for another one because it's their turn for 2. That's how the total 4.
Got it.
Got it?
Good.
Okay, okay. I appreciate your cooperation, guys. Sorry about this. Okay. I don't know. Till now, I haven't received, so I will check for this. But instead of wasting my time, I just put you in the meeting. I appreciate your cooperation. I hope you guys enjoy. This is good. I can see you. You can see me, but it's a smaller screen. It's a smaller version. Okay. Right? It's not like with the PowerPoint. For the PowerPoint, of course, like we need a big screen, but this is enough for revision anyways. I appreciate you guys are doing amazing revision. Tomorrow, I want you guys to come with the safety. Oh no, we will continue with this after the PowerPoint. There's only one. I told you the specimen storage and the integrity. We are going to do this interesting. We have repeated the information, so it's going to be another repetition. So no worries about that. We'll be doing total revision, revision, revision up until Friday. So you can all go get 80s, 90s in the final exam. Clear?
Yes, please.
Have a nice day.
Yes.
Appreciate your cooperation. Enjoy
Miss,
your.
I have a question.
Yes. Yes.
Miss, one of the paper that was sent, thanks to Evelyn, she sent it for me. The cross puzzle part is a little bit faded. Would you able to send that, please?
Yeah, I can do. No, tomorrow I can pull that page in the PowerPoint and then I can do that after the unit.
Okay, great. Sounds good. Thank you.
Yeah, because that has the final. After the PowerPoint, we have covered everything, so it's going to be revision. Anyways, I'll start with that revision, and then we can continue up until Friday. We can do the revision. Clear?
Thank you. Yeah. Thank
have
you.
A nice,
Thanks,
have a nice evening, guys. And once again, sorry for the inconvenience that's been caused. But anyways, we did a good job. We did a revision. Okay. Thank you so much, guys. I appreciate your cooperation. Thank you so much.
Thank you.
Bye,
Have a
everyone. Have
great
a nice
afternoon.
See you tomorrow.
Yes.
Bye-bye.
Bye.